All right. Good morning, everybody. This is Libby Clark. I am from Mercy Joplin. I'm the trauma manager of the program, and looking forward to this opportunity to speak to all of you guys. I picked a kind of a terrible subject for first thing in the morning, but I think we're just going to rip this off like a Band-Aid. It's a hard topic to talk about. So this morning we're going to talk about a mass pediatric casualty event. And knowing that this is every parent and every paramedic's worst nightmare, something that we don't want to plan for, but we have to plan for. I will give you guys a disclosure that I am not good at technology, so hopefully I don't mess up the order of these slides, and we'll get going. So here's my objectives. We're going to start out with, we're going to try to cover all this stuff. We're going to review some pediatric statistics concerning mass shooting events versus school shooting events and the differences between those. We're going to compare pre-hospital care in a direct threat setting and an indirect threat setting. We're going to go over pediatric triage, which I don't think I need to tell any of you guys about triage, but we'll just go over what that looks like in a mass casualty event. We're going to talk about the availability of evidence-based care of a pediatric mass casualty. And the spoiler there is that there is none, because luckily we don't have enough events to collect that much data. And we're going to talk about barriers to pediatric readiness in pre-hospital setting. We're going to look at Homeland Security, their pediatric specific focus, and also along with that, what's called TECC guidelines, which is Tactical Emergency Casualty Care, and it's a pediatric recommendation. So that would be from the military, not the civilian side. And coping with PTSD and emotional aftershock inside the EMS family, as well as families in our community. So here you see, these are school shooting incidents. And an incident is defined by any time a gun is discharged on school property, be that private or public. And this is by state per capita. And these are statistics all the way up till 2025. But they start in 1966, which was when the very first school shooting event had happened. We weren't really completely familiar with these things until 1996 was Columbine. And that was what really brought this to the forefront. Before that, we'd had an occasion here and there, but it had not been a mass shooting like that event. But these numbers do go back on this page to 1966. So if you look up there by population, of course, Washington, D.C. is a small area, but look at the difference between Washington, D.C. and Delaware. 7.81 per 100,000 and 2.06. So that's a lot of school shootings. So maybe we're not completely wrong by having the National Guard out there. Delaware, Louisiana, Maryland, Tennessee, Alabama, New Mexico, Ohio, Illinois, those are the top. Missouri is not far behind. We are number 14. We have had 64 school shooting incidents per capita since 1966 in the state of Missouri. These statistics I found came from 1960 to 2025, and these are just basic injury. So we've had 2,980 recorded incidents of a gun discharging in a school. And we had 2,385 injuries, 855 fatalities. Of those, 256 of those fatalities were the shooter. So these things never end well for anyone. Mass shooting events, the difference between this and the statistics I just gave you is that this is in any public arena. There's been 2,100 mass shooting events. Now, this statistics calculated mass shooting events as greater than 4 casualties. You will see some numbers that do not consider a mass shooting event until there's greater than 4 fatalities. These numbers correlated more with casualties, and I would say that that would count as mass shooting. I was at OSU this past weekend, and there were 3 kids shot. There were 2 shot the weekend before and 3 shot this weekend at a homecoming event. So I would definitely call that a massive shooting event. Luckily, it was after Grandma and Grandpa were in bed, so we were all off campus when it happened. But it brought it to the forefront as how close to home this can hit. So 9,000 plus injuries in these mass shooting events and 2,400 fatalities. The deadliest shootings in history so far to date: Robb Elementary, Uvalde, Texas, 2022. 21 were killed and 21 were injured. and Parkland High School, Parkland, Florida, 2018, 17 killed and 17 injured. And mass shootings, these are, larger venues and out in public. We had 60 killed. And I can't wrap my head around this number, but 867 injured. And when I first saw this, I thought, what on earth kind of weaponry could you have to hit 867 people? And then I think about those escape injuries. A lot of your injuries will be escape. A lot of your injuries in these situations will be trampling, will be jumping off of high places to escape. They're not so much that. And then also, in Las Vegas, you have a lot of elderly people on vacation and gambling, and you may have heart attacks. You may have all of these things. So 867 injured in that episode. The Pulse nightclub is behind that. 2016, there were 49 killed. So the thing about mass shootings versus school shootings is that your pediatric fatality rates are much higher, obviously, in a school shooting. So in a mass shooting, you can expect 15 to 20% of your victims to be pediatric. In a school shooting, you can expect 93% of your victims to be pediatric. And that is a big challenge with pediatric supplies and training and so forth. I think this is my last statistic slide. Most all shooting events that have occurred in the last 5 years. So if you look at this, I am not sure what happened in 2005, but there was a big spike there. And that tends to be where people really started keeping track of these numbers. But if you can see, these numbers only go up to 2022. And you see the sharp difference between 2019 and 2022, really with the biggest spike between 19 and 20. And the thing that's crazy about this is that these weren't all school shootings because nobody was in school that year. It still didn't deter things. Everyone was stressed. People were out of work. So that certainly could have contributed to those numbers spiking. The numbers, the good news, not good news, but from 23 to 25, we have seemed to plateau. The latest numbers that they have that are not official, this is the CDC's website, that we have not broken 1,000 yet. And these specific numbers are not just mass shootings. I didn't mention this at the beginning. These are intentional firearm and pediatric homicides in a public space. So these are specifically children killed only in mass shootings. That's what that number reflects. So the question that we have is not, if this is going to happen, but we have to think about when this will happen, and that is very, very scary. So we'll get into some of the management here. There's different ways that you divide both time and space when you have a mass casualty event. First of all, as far as time is concerned, you have your direct threat phase, which we'll go into the definitions of all these. And then you have your indirect threat phase, and then your minimum possible threat phase. It is called the no threat phase, but I don't like to call it that because you are never, as long as you are on scene, you are never out of a threat possibility. And space, you guys are familiar with this. You have your hot zone, your warm zone, and your cool zone. Hot zone would be where the direct threat is still in progress. Warm zone would be where you may be hazmating, or you may be, maybe you're cleared to go in part of the building, but not all the building. And then your cool zone would be the place on the property where you take care of the patients and hold them while they're triaged to go to the hospital. So the direct threat phase that occurs in the hot zone. So this is when the active shooter is still believed to be inside the structure with the victims. The hostage situation may be in progress. You can hear active fire exchange in progress. EMS will be staging for the safety of the crew. And we'll talk about that a lot. The goal for this is to be the shortest phase possible. They want to get in and neutralize that shooter or neutralize the threat so that you guys can get in and do your job. The reality and perspective of EMS is that although this is the shortest possible phase, it is an eternity. It is the longest wait I could imagine. And this is something that not really doing a lot of field work. I've been in the field very few times. this is the part that nurses and doctors do not understand what you guys go through. And I cannot imagine sitting and waiting to be cleared to go take care of children. So we're going to talk about staging. I have a friend who is an FBI agent that I contact every once in a while. By the way, the FBI is embedded in the 4 states right now. Their SWAT team is here and they have active situations going on. So he checks in with me quite a bit to make sure what entrance he'll bring people. So I call him and I ask him, how far was safe? And he said, well, can you cover the scene with your thumb? This is him being funny because you can hold your thumb out and you can try to cover the scene, but where's your thumb? You know, that's all relative. So the distance can be relative. Do you know your policies? Does your organization have guidelines? I'll say something here about policies and guidelines. In a situation like this, policies are not something that you're going to be able to follow. You are going to have to follow guidelines because these scenes are dynamic, they're changing. You're going to have to do some problem solving out there. You can't just be black and white on policies. So I would say, does your organization have guidelines? The hospital calls these clinical practice management guidelines. If you can know your guidelines ahead of time, then when you're in fight or flight and you're taking care of these people, hopefully that those things will guide you. But you have to do sometimes what you have to do. So policies are not super realistic in a dynamic, direct threat environment. The time that it takes to clear a stain, it depends on the size of the building, the public space. There is no set determination for this. You have additional threats. You may have multiple assailants. Things like this are going to make it longer before you can go in. The law enforcement that clears the scene, they make a primary and secondary sweep and assessment, much like we do when we assess our patients. You go in and neutralize the threat first. That would be your ABCs. And then you go back around to look for any other threats. You know, was there a bomb threat? Did we use tear gas? Things of that nature. Staging is the practice of positioning an ambulance at a safe distance from the direct threat environment. This area can be well defined in some mass casualty incidents, but obviously it's very adaptive and progressively changing in an active shooter incident where your threat is moving, your threat is running, your threat is hiding. The goal is to protect and shield those who will be rescuing others. So proper staging enables EMS to provide the most care to the most victims. And this is a hard concept. I know that you guys are trained for this. We do this in the hospital as well. If we were going to have an active shooter, our instructions are to hide, not to rescue, until it's neutralized so that we can take care of most people. And that is very hard. So selecting a staging location, choose a location out of the line of sight. You don't want to draw any attention to you, either from the victims or from the villains. And this next line is another thing that really helps me understand some of what you guys go through, and it choked me up. Be aware that a victim running towards you will place you in the direct line of fire. And I don't know how you would ever face something like that, but it's a reality. And so staying out of sight is not just for your protection, but for the protection of your victim that might be running for help. So no lights or sirens. Have an exit strategy. These are basic things that we're just going to review. Sorry about there's a typo up there, I see. Avoid dead ends and assess for obstacles to get a quick getaway. You want to know your active shooter can create a rapidly changing hot zone. Communicate with your incident command is going to be vital because your scene is dynamic and changing. So rural considerations, most everyone that's listening to this is probably from a rural setting. Even Joplin is considered by some communities to be rural. We have much more wide open areas around our schools. It's a lot harder to stay out of sight in a wide open area specifically. You know, parts of Kansas and Oklahoma you can see forever, it seems like. So know your area, know what your special issues would be. Look around your local schools, your church, your parade routes, your venues. Most all of our small towns have parade routes along the same line every single time. And know what your barriers are going to be before you are placed in that situation. Also, it says in the literature I read that high energy and long range hunting rifles are more prominent in rural areas. This may not be so. It might be. All guns are available everywhere. However, if you do have that kid that gets his parents' gun in a rural community, the odds of him having access to a long range hunting rifle is much more common. Okay, so now we're talking about the indirect threat phase. This would be considered a warm zone. So this is defined as the time period between the primary and the secondary building clearance. Even if the shooter has been neutralized, there's still going to be indirect threats. Some examples of this, and one of the biggest ones I would see would be parents in fight or flight who may also be armed. In your rural communities, people are carrying guns concealed. They have concealed permits. These parents are looking to help, and they're going to be in your way. And so parents in fight or flight can be just as much of a threat as the shooter. Additional threats, I mentioned a bomb threat. You know, did we use tear gas or other deterrents to neutralize the assailant? We had a tear gas incident a couple of years ago that we actually got in trouble at the hospital for not hazmating. First, we had, this was the guy that was at a hotel, if any of you remember that. They used tear gas, couldn't get him out, and he ended up getting shot with a beanbag, and it was right directly in his mouth, in his teeth area. So he came to us without an airway, and we were not going to stop and hazmat him. Apparently, we should have stopped and hazmated him because we put our entire trauma room at risk. One of our nurses' eyes were completely swollen shut by the end of the short time that he was there in our trauma bay. So it is a threat, it is a problem, and it can be pretty significant, and it can keep you from doing your work. So just be aware of those other deterrents that are used. Also, in any kind of a shooting event or threat that you might have called, they always talk about unsecured bags. How many backpacks and lockers do you think is in a public school? I cannot imagine trying to make sure that a scene is clear if you had a bomb threat in a school. I know it happens, and we have dogs. We have things to deal with that, but it is an enormous amount of things that would need to be cleared. EMS may be allowed into the building during this indirect threat phase. It's going to be up to your incident commander. You may be allowed in part of the building to begin triage, while other parts of the building are still being cleared. It just depends on how big your building is. So here we go. Your scene is clear. It's time to start triage, time to go in. There's no preparation emotionally for the strain that you're about to see and reality of having to leave someone behind. A lot of you have been involved in military operations, and you have seen this firsthand. A lot have been involved in the tornado and have seen incidents of this scale. It's still, there's no way to completely prepare for this. I'll tell you, many of you online may remember a medic that was here. Her name was Jen Russell, and I will never forget her the night of the tornado. I felt helpless. I was at Freeman. I was trying to help. I didn't know where anything was. Didn't know, nobody knew me or what I could do. I felt helpless. And so I ended up going out into the field to help triage. And we were riding in the back of the ambulance, my first time in the back of an ambulance. And we were swerving around couches and things. And we get ready to get out. Of course, I couldn't see out the windows the whole time. And Jen turns to me, and I'll apologize for my language. She said, "Are you ready to see some shit?" And I said, "No, but let's go." That's kind of how I face that. But I've been in that where you just don't know what you're about to walk in on. So the choices must be made to do the most good for the most victims. Realize what your resources are. Sometimes, you know, your triage is not just who goes next or who do I care for first, but it's how far can they go? Where do they go? What are your resources? So we'll go through just the triage. I'll use the color method. I know that there's other methods people use, but your red patient is your patient that needs intervention for a life-threatening problem in 15 or 30 minutes. Your immediate nearest facility is where this patient needs to go as quick as possible. Your yellow, those are your 1 hour urgents. They need something life-saving. They may be able to wait an hour. If you're choosing between hospitals, they may be able to go a longer transport. But you need to make sure that they go someplace with OR and surgeons. Your green patients, those are your walking wounded. Walking wounded can be a challenge and sometimes can be easy when you're in a pediatric setting. They can be routed POV to urgent cares even, or outlining facilities if maybe they just look like they need stitches or something. But be aware of radiology subspecialty availability. You don't want to send somebody to a place that does not have surgeons available, obviously, if they may need surgery. Some of this too, for example, both hospitals here in town sometimes have coverage issues. And in that time where you're waiting for the direct threat to be cleared, that would be a good time for incident command to be making sure what hospital resources there are. For instance, right now we have a neurosurgeon that is out. So we have 3 days of the month that are not covered with neurosurgery. That would be good to know ahead of time while you're planning on where you're going to be taking these victims. So things like that, just know who has what going on. We have an exercise that we do once a month at the hospital, and it's random and it's supposed to be a surprise, but I'll get a phone call when I'm charging and it says, how many victims can you take if we had a mass casualty incident? And we are supposed to look at our situation right then and our status and our surgeons and count how many of what level that we could take. And they take that information from all the hospitals and they determine what scale of an event we could handle at that moment in time. And it's always kind of a shocking phone call when it comes. I try to take it really seriously, but that's one of the things, just being prepared for what you could take and when. So I'm a black patient, that's triage black, that's no sign of life at all. And this will be where our first major difference comes with our pediatric patients versus our adults. So triaging black in pediatrics, impossible to walk away from somebody that needs help. This will leave a mark on you forever. Another thing that I can't imagine, but there's a possibility that a healthy child that has no background problems, that has been triaged possibly as black, can become red with minimal intervention. And so you really cannot triage a child as a black patient until you have opened that airway, attempted rescue breath, and decompressed that chest. Do they have a trachea deviated? That is one thing that you can do very quickly that suddenly makes your child red and able to have a life-saving intervention if we can get them to a hospital. So anytime you decide an unresponsive child's triage level, they do want you to stop and give breaths and make sure that it's not a chest decompression issue. Briefly, we'll go over just the basic differences. I'm trying to concentrate more on the event organization than the actual anatomy here, but we'll go through this. I know this might be redundant for a lot of you, but your airway, larger tongue. They've got a smaller jaw. Their heads are big. The airways are more easily obstructed because they're flexible. Their trachea is shorter and it's narrower. The adult, of course, has larger airway diameter, more rigid structures. We've always kind of gone by the pinky rule with kids. The size of their pinky is the size of the tube you need to use. And the practice now is to have all cuff tubes for children. So pediatric, more compliant chest wall. They have horizontal ribs. They have less protection for their lungs and their heart. They have a rigid chest wall. In adults, so their organs are better protected. Circulatory, higher heart rate at baseline. They will have a lower blood pressure, smaller circulating blood volume. So if you have 80 mils per kilogram, a child, a grade school kid may only have like 1.5 liters of blood total. And so their blood loss is going to hit them harder than an adult that might have 3.5 liters or more. So the adults have a lower heart rate and higher blood pressure. They have a larger absolute blood volume. We've already said their head is a large body ratio. They're higher risk of head injury and heat loss. Also, you lose a lot of heat through a larger head. Most of your children that are in school, they have adapted to the size of their head more. This would be more a serious problem with a toddler. So adults have proportionally smaller heads. Bones, just like their ribs, their bones are softer, have more cartilage. They tend to have green stick fractures. Adults have more complete fractures, and what this will look like differently is that children won't have the obvious deformities that adults will. So I'm just going to go quickly here through the ABCDs, which don't start with A. In this situation, most likely your top priority is going to be uncontrolled bleeding, and that is where they tell you to change your priority. You have got to stop the hemorrhage first. The greatest indicator of survival in anyone that is bleeding is the time that the bleeding is controlled. So bleeding is most likely going to be more of a priority. Stop the hemorrhage. Do not hesitate to use tourniquets on pediatric patients. Most of our adult tourniquets will go down to about 13 centimeters, which would be the thigh even on a small toddler. So you can use tourniquets. They go down pretty small. Of course, we'll face it, a lot of our school-age children are adult size. Anyway, but don't hesitate to use those. Older children might be able to hold direct pressure on themselves and have very little instruction. You'll be surprised what an older school-age child can understand, being more literal and black and white than maybe a high school teenager. Airway. By the way, I put some cute pictures in here to lighten up this topic here. So airways may need a towel or a blanket roll if they are younger and have the bigger heads to be able to elevate their shoulders to open their airway. Cricothyrotomy, this will be something hopefully you never run into this, but you might. And one thing a paramedic at a conference I was at said is that no one should go to the morgue for an airway injury without a hole in their neck. They should not. They should have an attempt at this. So if needed, a cricothyrotomy, look for signs of puberty. If there's no signs of puberty, you can use a large bore needle, and that will be sufficient. If they're older, then you will have to use the cut down techniques. I don't know what kind of kits that you guys carry. Ours do have a scalpel in them. That would be organization specific. In a mass casualty situation and really moving to any situation, bag valve mask is equivalent to intubation. You do not stay on scene in the warm or the hot zone to intubate a patient. If you can bag them, you can move them. And the majority of pediatric patients, once their airway is open with an oral airway or a nasal airway, bagging them is considered a secured airway. Breathing. Do not ever, ever, ever rely on a pulse oximeter for any reason on a child. They will compensate until they do not. Especially not just in this situation, but asthmatics, they will not drop their pulse oximeter. If anybody has ever tried to hold their breath until the oximeter goes down, it's almost impossible. You can be 95%. However, if you leave that pulse oximeter on after you start breathing, you'd be surprised at how low it goes, because the pulse oximeter follows about 60 seconds behind what's really going on. So rely on their work of breathing, their color, their mentation, their respiratory rate. If they look like they're having trouble breathing, they're having trouble breathing. Needle thoracostomy, I'll go into this a little bit more detail on the next slide, but the gauge of the needle and location is the same as for adults. This is a difference between tactical and your typical EMPC and PALS. The gauge of the needle is going to keep you from clogging up. In this situation, in a shooting situation, you're going to have hemopneumothoraxes. It's not going to be air, it's going to be blood, and it's going to clot off just like anything else. So don't be afraid to use an 18 or even a 16, 14 on a small child. Just be cautious with the depth that you're using. So here's your spaces. There's a debate about this. It's changing. You have your second intercostal midclavicular or your fifth intercostal in the mid-axillary. So the risks and benefits of both of these, it's obviously easier to locate the second intercostal. You put your hand on the clavicle, middle of the clavicle, and go down to between the second and third rib. It's also the least effective, though, with studies are shown that they clog off easier, they don't go deep enough. There's also a really high risk of injury to major vessels. But currently, PALS and EMPC still use this as the best practice. The fifth intercostal mid-axillary is considered the better if you are trained. It takes special training, but it is the most effective, and it's the least risk to injure major vessels. Currently, ATLS has already changed to this as their best practice. A word about circulation here. In pediatrics, in a mass shooting event, a mass casualty event, IO needs to be your very first attempt. Do not stop and try to get an IV if they need one. You can get that later, get an IO in if your patient is hypotensive. The rules on the bolusing: 20 mils per kilo bolus on any kid. Of course, you'd have to use your Breslow tape or just get good at your carnival guessing in this situation for weight. Saline can be repeated once. However, if you are in the presence of obvious large amount of blood volume loss, skip straight to that 10 mils per kilogram of packed red or whole blood if it's available. Some, I know MedFlight and Lifeline carry whole blood, but the best case for a bleeding patient is blood. So rather than mess around with a second bolus of saline, you're going to want to get that on board. Your BP or systolic should be at least, and this is my rule of thumb that I use on all peds,